Good morning, everyone, and welcome to Global Cleveland's second annual Welcoming Week for the year of 2020. My name is Beju Shaw. I'm the Senior Fellow for Innovation at the Cleveland Foundation, also a founding chair of Global Cleveland and an ongoing board member. Welcoming Week is a way of bringing the communities together to celebrate the unity and strong connection we have with one another and exhibit and applaud the benefits of welcoming newcomers to our region. This year's Welcoming Week kicked off Friday, September 11th, and will end this Friday on September 18th. And you can check out all of the events that Global Cleveland is hosting on our website, www.globalcleveland.org. I want to thank our amazing sponsors and partners who have supported Global Cleveland's efforts to help and serve immigrants and newcomers who come to our region for economic opportunity and better life. Thank you to our generous event sponsors who have made, in particular, this Welcoming Week possible. You saw many of their logos on the slide that was up in front of you, but I'll just mention them quickly. Cleveland Cavaliers, Marcus Thomas, United Church of Christ, Northeast Ohio Relocation Guide, Cuyahoga County Board of Development Disabilities, Bank of America, Dealer Tire, Catanese Classic Seafood, Alexander Man Solutions, Eli's Landscaping and Design, Medical Mutual, International Law Group, the NRP Group, Destination Cleveland, the Legal Aid Society, Margaret Wong and Associates, Dave's Market, Cuyahoga County, the City of Cleveland, Downtown Cleveland Alliance, and WKYC. Thank you to all of our sponsors for investing your time with us. Today, I have the pleasure of introducing an amazing panel on the topic of public health access in our international community, where the panelists will be discussing services and access to information, in particular for the international community, especially during times like the ones that we face here this year in Greater Cleveland. So let's get started with the panel introductions. Our moderator is Kirstin Craciun. Kirstin recently directed community outreach efforts for the Center for Health Affairs, where she developed the first joint collaborative community health assessment in Cuyahoga County in 2018 that brought together our hospital and public health partners. Thank you, Kirstin, for moderating this panel. On our panelists, we have John Corlett, President and Executive Director for the Center for Community Solutions. John's career has been extensive, has included leadership roles in both the public and private sectors, and he's been the recipient of many state, regional, and local awards for his service. Our next panelist is Matondo Ngemba, who is a graduate student at Cleveland State University pursuing a master's of public health. Matondo is a refugee from the Democratic Republic of Congo who moved here in 2011. She's a passionate advocate for human rights with a focus on refugees, women, and children. The next panelist is Susan Fuehrer. Susan joined the MetroHealth system in 2019 and serves as the president for the Institute of Hope, Health Opportunity Partnership and Empowerment. Susan joined MetroHealth after a long and distinguished career, retiring as the president and CEO of the VA Northeast Ohio Health System in 2019. Our next panelist is a licensed independent social worker in Ohio, Faye Lee. Faye currently provides bilingual counseling, supervision, and case management services at ASIA Services in Action and the International Community Health Center. She's originally from Jilin, China, and speaks both Mandarin and English. Next panelist is Michelle Wilcox. Michelle serves as the Community Engagement Coordinator for Neighborhood Family Practice, where she educates and advocates for patients and the broader community related to the overall health and well-being. She manages the community health initiatives by leveraging internal and external resources to meet the community's needs and improve patient health outcomes. Our next panelist is Dr. Nizar Zein, who serves as the Chairman and Medical Director for Global Patient Services at the Cleveland Clinic. Dr. Zein is the recipient of numerous honors and has served in multiple leadership committees at the Cleveland Clinic and has always been a passionate advocate for quality and compassionate care, in particular for international patients. And then our final panelist for this morning is the Chief of Public Affairs for the City of Cleveland, Ms. Natoya Walker-Minor. In that capacity, Ms. Minor provides executive leadership, drives policy, and facilitates execution and implementation of the mayor's priorities across 7 departments to meet the vision established by the mayor, which includes public health for all residents of our city. Thank you to all of our panelists for being here today. It's going to be an exciting panel to hear your perspectives. I'm going to turn it over to Kirstin, who will now begin the panel.
Thank you so much, Beiju, for that very warm welcome. I'm so excited to be part of Global Cleveland's Welcoming Week and all that it stands for. I can't wait for all of us to learn critical information from our very diverse panel of experts as we learn about public health access in the international community. So I will be asking the panelists a series of questions, and I invite the audience, thank you for joining us today, to please submit any questions that you might have using the Q&A feature. And we will try to get to as many of those towards the end of our discussion today. So why don't we go ahead now and get started. So Faye, I would like to start with you. I'd like to provide the following context. The COVID-19 pandemic has really, as we all know, upended almost every aspect of life as we know it. How is your organization involved in the COVID-19 response, and what essential information do you want to share with our international community during the pandemic?
Oh, thank you, and good morning, everyone. So Asia Social Service in Action has two locations. One is in Cleveland, one is in Akron, and we do have social service departments and international community health center. So during starting when the pandemic started, we all try to adjust how we provide services. So Asia has been continuing providing the services, just following the social distancing guidelines. So at International Community Health Center, we have been provided telemedicine and the limited face-to-face appointment for care and mental health services. And recently, there's a COVID-19 testing started on a Friday afternoon at our Akron location. And we also reach out to the wellness outreach calls to our patients, high-risk patients, and explain to them what the precautions and what the services are available, including what are available in the community, like MetroHealth clinic, any big hospital systems where other services are provided. On our social service part, we started to provide services to help people to apply for unemployment benefit and provide food services, what are resources available in the community. And I know for Chinese community, we started like a WeChat group chat. People can access what resources in the community without English capacity because it's in Chinese, so the messages are in Chinese. Within the agency level, we also hold some monthly self-care sessions for our staff, talk about mental health, stress, and also we host like Zoom conference with government officials talking about what are the needs of people, communities with language limited and cultural competence. So thank you. I think that's all.
Thank you so much, Faye, and congratulations to Asian Services in Action on the recent launch of your testing clinic and the Akron location. That's wonderful, and it's very clear that you've been able to provide a comprehensive set of services. So thanks for all that you're doing for the community. I'd love to hear now from Sue Fuehrer from the MetroHealth perspective on this question.
Good morning, and thanks everyone for joining. Very proud at MetroHealth. We were one of the first to stand up a 24-hour, 7-day-a-week COVID hotline. We started that on March 13th, and to date, we have received more than 30,000 calls. And of those 30,000 calls, 14,000 were referred very timely to a telehealth or televideo provider where they could get immediate assistance for their COVID-19 symptoms. But in addition to providing that clinical care, more than 9,000 calls were also referred to a social care coordinator or care navigator, where we looked at all the other things that may be impacting someone that is experiencing COVID or was quarantined for COVID. So of those 9,000 calls, we have done deliveries to 1,400 homes with food, cleaning supplies, masks. We have put together at the Institute for Hope more than 1,200 homeless kits that were delivered to homeless shelters as well as camps so that people had the necessary supplies that they needed to keep themselves safe. And we have partnered. You know, I think the big theme is partner and collaborate. None of our organizations could do this together. So we partnered with many people. One of the majors has been the Cleveland Food Bank, where we have distributed more than 56 tons of food, either through direct home deliveries or distance food clinics so that people could get the food that they need. In addition to that, we've done more than 1,000 warm line calls. We know through our social determinant of health screening that social isolation was a big issue before COVID hit, and it is, you know, only gotten worse. So through faith-based calls, warm line calls, behavioral health calls, we have really been working to make sure that people can be socially connected as they need be. And the last thing I'd like to talk about is that MetroHealth does do resilience circles, and we have been really working with our frontline responders during this time. That it's been a very stressful time for them, both at work as well as trying to balance their home life. And we've been doing resilience circles with them to help them identify ways that they can cope. And of course, we're seeing an uptake with that now that frontline workers have kids that are half in school and half at home and trying to do all that. So those are some of the things that MetroHealth has done specifically. Oh, I should add that we have done 10,000 tests, COVID tests, in some of our poorer neighborhoods with our faith-based communities. Those are tests outside the hospital setting. Those are where we are going to the poorest neighborhoods. We have an ongoing schedule of that. And I would just like to encourage anyone 24/7 that has any questions on COVID, immediately available in English or Spanish, but translation services are available. Our COVID hotline number is 440-592-6843, 24 hours a day, 7 days a week, any language. Thank you.
Thank you so much, Sue. That is wonderful, and I loved your visual aid. And as a working parent, I can totally appreciate all of the things that I love. You're also paying attention to your staff on the front lines. And thanks for all that you're doing, the attention you're paying to the vulnerable communities. And I think it's so wonderful, all of the partnerships that you've been able to establish so quickly here. That's wonderful. I'd love to now turn it over to Chief Walker Minor to hear from City of Cleveland's perspective on this issue.
Sure, and good morning, and thank you for this invitation to be present with you all. And like Susan indicated, partnership is the key. None of this could happen without the partnerships at every single level in this community, whether it's with the healthcare institutions, the nonprofit organizations, the community-led organizations on the ground. We have been in this together collectively in Cleveland. Within the city of Cleveland and our general structure, early on March 17th, the mayor of the city of Cleveland declared an emergency for the city following the governor of Ohio. And what that enabled us to do was really to create an executive policy committee so that we can make decisions quickly, very fast inside of our organization. The Department of Public Health has been on the front line in terms of epidemiology, responding to and identifying the cases, working very diligently with nursing homes, doing an amazing job. The staff, essentially 100%, were reassigned to work on this. Outside of that, however, our public safety, our human resources, we made our finance office, we made the adjustments inside so that we could rapidly respond to this in a way that postured the city in a proactive way for the people. We work diligently with the Office of Homeless Services. The homeless component is a very vulnerable component, and literally early on that first week, we worked very closely with MetroHealth, the Office of Homeless Services, and nonprofits in this community, Ohio City, the campus district, to determine a way to make sure that we had porta potties, but not just porta potties with wash stations. We had 10 of those across the community. And we wanted to do that to make sure that people were able to wash their hands. Because you remember early on that first week, it was all about hand health and sanitizing our hands. So it was not enough to have porta potties. And so we worked diligently so that we can do that. And then we worked with Lutheran Metropolitan Ministries to make sure that, and the YWCA to make sure that men and women who typically sleep on the street and are hard to serve, that choose to sleep on the street, that we could place them in the hotels. And the hotels in our community have been an extreme partner as well. Who would have thought that they would have set aside time, months actually? They're still there. So we're 6 months in and we have 6 hotels that we have been working with over the last six months to make sure that homeless persons that may be positive, they're in a separate hotel. So working diligently even with the corporate sector to make sure that that works. And then working with the university hospitals made a huge contribution on masks. Another organization out of California donated masks, and working through our Office of Minority Health to make sure that on the ground, people had access to masks. We had about 150 employees that are recreation staff employees that were at home for maybe the first 6 to 8 weeks during the pandemic. And we called them back and had them walk literally every single ward in this community in the form of education and information. Why did we do that? Because public health is all about education, intervention, outreach, prevention. And then some of our partners like John, who's sitting there, and I hope he's not embarrassed, but he and others donated food on a regular basis early on to the Department of Public Health because our staff early on were working extremely long hours. And collectively, I'll just say Cleveland is so very fortunate to have a servant's heart across our organizations, whether it's the hospitals or the nonprofit sector or the community-based sector. And what we did is we rose up together. And when I said early on that we're in this together, I meant that because people really took down their guards, placed their egos aside, whether it was healthcare, nonprofit, or community, or parent group, and said, how do we dig in deep to make sure that we can preserve the life and health and safety of Clevelanders?
Thank you so much. Those are so many wonderful examples of partnership, collaboration, and just general human goodwill. And I think that's so wonderful. And I think it's so important that we keep boosting up the folks on the front line and letting them know that we're all cheering for them. We all can't serve on the front lines, but we can all find ways to support them. And I think you had some really nice examples in those. So I thank you for that. I would love to turn it over now to Dr. Zein to hear from Cleveland Clinic's perspective how you've been engaged in this effort.
Thank you, Kirstin, and thanks for the organizers of this panel. I think before I go on the path of actions and accomplishments, I just want to regress to say that really this pandemic, the impact on human life and suffering is not to be minimized. So no matter how well we have done, we clearly have not been able to save hundreds of thousands of lives. We have not been able to save, I think, at least over 1 million individuals who lost their jobs in Ohio. So a lot of good actions, but we aspire to do better in the future. But let's go back. So this pandemic really is a cover-up of 3 pandemics: health pandemic, economic, and racism pandemics. And I think they will all likely be addressed in this group. From Cleveland Clinic perspective, I think we are lucky by having visionary leadership as well as supportive community where we reside in Cleveland. I think if I have to characterize the response was one swift response and early response. So we established the COVID-19 command center with top leadership representing all the way from supply chain to clinical services to quality and safety and so on. We established that before the first case was ever documented in the state of Ohio. So we really early being ready is very important, and I think that's what I credit our leadership with, having the vision to anticipate what may happen and begin early. A second characterization of the response of the clinic was fully collaborative. So we worked with University Hospital, we worked with Metro, we worked with the city of Cleveland, with the police department, we worked with the health department in the state of Ohio, and we were in daily, and this is truly daily contact with the mayor's office and so on. The mayor and the governor's office for the response. So these two things are very important and probably led to saving some lives along the way. If you look at what was the focus of this team, the focus certainly internally was on, number one, increase bed capacity. We were really concerned that we're going to have a flood of patients requiring inpatient care or intensive care units, just like what happened in New York, what happened in Italy, Spain, and the list goes on and on. So part of that effort led to canceling, of course, of all elective procedure, which was a mandate by the governor. But as importantly, we led to the establishment of what we call it the Hope Hospital, which was established in the site of the Medical Education Campus in partnership of Cleveland Clinic and Case Western Reserve University. Hope Hospital increased our inpatient capacity by 1,000 beds, and of course cost a lot of billions of dollars and a lot of work, and in the end we did not use it, but we are happy we did it. And I think there's a lot to learn along the way if in case we are faced with future crises. The second piece of the response focused on how can we protect our caregivers. Ultimately, we cannot take care of the patients if half of our workforce get infected with COVID-19. So to do so, this highlighted the need first of technology to make sure people who do not need to come to work can stay home and work from home. But more importantly is to provide PPEs. So one of the things that COVID-19 uncovered is how easily supply chain path can be disrupted through a global pandemic. If you look at the United States, 80%, and that is 80% of consumer goods are imported. So you can only imagine how difficult it is when you don't have local manufacturing to maintain supply chain in a situation like this. So part of the collaborative effort is that Cleveland Clinic went to work. We created our own initially masks. We worked with the Amish community to upscale the production of masks and face shields later. We tested different fabrics to working with local manufacturing groups to create gowns and so on. So the whole, a lot of effort went into protecting our own caregivers, and only to do that is to have sufficient supply of PPEs or personal protective equipment. In case you don't know what that is gloves, masks, face shields, and gowns. Finally, I think Cleveland Clinic stayed true to its mission of innovation. It's part of our mission 100 years ago to advance the science of medicine. And this became particularly important in the era of COVID, where our innovative colleagues invented cheap, quickly manufactured ventilators at a cost of $500 as opposed to $10,000 or $20,000 of a regular ventilator, tested them created capacity to manufacture them if we needed. We had innovations around making one ventilator supply to patients simultaneously with ventilation. We had innovation around creating what we call it prediction models to identify who is going to get sick from COVID-19 and can get sick quickly, so we can direct resources toward that. We created predictive models of our own healthcare givers who is going to be at risk to acquire COVID-19 based on their work and the certain characteristics, so we can particularly provide the protective equipment for this population. I will finish by saying how would that apply to our international community, since this is why we are here now. And it does in many ways. So we serve two types of international communities. The first of which is international patients that fly from across the globe, from about 140 different countries globally, to Cleveland, Ohio for medical care. And these are several thousands of patients. What we found out when COVID happened and there was travel ban, that we had about 150 families or so that were stranded in Cleveland, Ohio. These are individuals who came for medical care but could not return back home. Most often they spoke little or no English. Most often they really didn't have the sophistication now to survive in a lockdown situation. So for that population, we as an organization, me personally, I did that every weekend in my own car, delivered the food, masks, sanitizers, and educational material about what is COVID, what are you supposed to do and not to do, and how can you manage. And we worked with foreign countries to actually be able somehow to, through chartered planes and so on, to take some of these individuals back to their home countries. The second population we serve are the local immigrants, refugees, and other population. We participate, and this is the department I oversee, in providing language services, coordination, and other needs of this community. So collectively, we manage about 50,000 appointments a year from this diverse group of communities, the immigrants and refugees. And for that, we actually had to work with those communities on how to manage virtual medical care and how to provide, during a virtual care, how to provide interpreting services online and how to manage their medical needs, whatever needed. I will stop here and maybe we'll have more chance to comment on these later.
Thank you so much, Dr. Zein. I really appreciate all of that Cleveland Clinic's been stepping up and helping with preparations and working on the personal protective equipment issues as well, along with serving the international community in a variety of ways. I'm going to come back to you in a minute. We're going to move on to the issue of mental health. I know Dr. Zein had referenced that, we can't ignore that this pandemic has had a major toll. It's taken a toll in a variety of ways. So we know that mental health concerns and speaking about them publicly can sometimes be uncomfortable for all of us. Yet we know that rates of stress and anxiety have been amplified because of the pandemic. Matondo, I would love to turn it over to you to speak from your very important perspective on ways organizations should be working to decrease mental health stigma and ensure that our international community is supported during this challenging time.
Thank you. Hi. So the first thing that I would say is the organizations being able to understand how the community understands mental health.
We can't hear you.
Matondo, can you turn up your volume or speak louder?
Yeah, can you hear me now?
It's a little better. Maybe just speak as loud as you can.
Okay, how about now?
Much better. Thank you.
Okay, awesome. So as I was saying earlier, the one thing that organizations should, I think, do is understand how these communities understand mental health. Because coming from like an American perspective, we all have a pretty good understanding of what mental health is. But when you look deep into communities, and I can speak for my own community, is that when they think about mental health, they're thinking someone with like extreme psychological problems. They're not thinking about stress, anxiety, depressions, things that we face on a day-to-day basis. So first, being able to tackle that stigma or misunderstanding of what mental health truly is, then we can truly better serve them. And just placing individuals in communities that will start these conversations. One thing that I personally do is whenever there is a community gathering, wedding, funerals, unfortunately, or even parties, I'll just say, hey, how are you guys feeling? What kind of emotions are you processing? How are you helping each other? How are you being there for each other? And so the conversations will start, and the people will come together, start talking, and then I'll just say, this is what a group counseling session would look like if you ever were interested in signing up for one. But when you mention something like that, oh no, we're not crazy, that's for like somebody who's crazy, That's the first thing that I would say, being able to break down that stigma of mental health being somebody who's extremely crazy, but having them understand that it's actually something that we all need, and it's something that we all face every day.
Thank you so much, Matondo, for that really important perspective. That's really helpful for all of us to hear, and particularly on the provider side as well. So thank you so much for sharing that. I'd love to hear now from Faye, if you could speak to that from your organization's perspective, how you're working on this.
Oh, thank you. Matondo, I really appreciate your perspective with how different community perceive like mental health. So in Chinese community, I can say that the same way, like people want to confirm if they are crazy or not, But also going back to how pandemic impact mental health, I want to say that, many international community, I have to say the underserved, like the one with Chinese, with language barriers or cultural competent. Many of this population, people has been experienced a lot before this happened, like different layer of trauma before. So people is very resilient, and sometimes they kind of put on a shield, like I can handle this no matter what it is. But pandemic certainly is not anything we experienced before. So somehow now the conversation started, no matter how we perceive it. Mental health become like on the water, everyone started to talk about it. So as a professional, like a counselor, I'm really like excited. I feel like this is the opportunity. We can bring the conversation back to the community. So at our clinic, when people come for the primary care, sometimes when they talk about any stress, the provider, they will let us social workers go in to talk about it, just like, okay, what can we help? How can we address it? Not particularly say we are providing mental health services, but more is like connecting to the care. And then me and our agency, we are launching like a community outreach activities. So we're planning to going to Nepali speaking community, Chinese speaking community, create like through the visual platform, maybe talk about different health or mental health related topics, and create some YouTube video to put out there in the community, in Mandarin Chinese, in Nepali, so that people may kind of able to recognize different red flags. And if they need help, they know where they can go, which number they can call, and how to access to the resources. So that's the kind of initiative we take the opportunity of pandemic as agency we are going to do, to bring the service to the community. And then if they need it, they can come to us. So we are more like a hub. as our role in the agents as a small clinic. Thank
That's
you.
great, Faye. That's great. I love how you described all of that, and just really appreciate the role that you're serving. And you know, I think the YouTube videos, what a great idea and great way to try and find connection during this time. I'd love to hear now, Dr. Zein, coming back to you from the Cleveland Clinic perspective on this issue.
Okay, thank you again. I think this is a really tough question and tough issue to address. Mental health at large is difficult to navigate because there are many factors that interplay, including the culture, which is very different from one ethnic community to another. There is the stereotyping, or that just mentioned by Matondo and Faye. There are issues related to access. So insurance products frequently do not cover psychiatric counseling and help. And then there's the issue of access itself. There is significant shortage in mental health services. And I'm talking about our own local community here in Cleveland. And finally, the language layer, where the treatment of a psychiatric anxiety, or not necessarily anxiety or stress, or all of that may require some counseling. Counseling can only be effective in the native language of the patient. So you have to have enough providers who speak that language to support that community. So I would say the complexity is quite deep and difficult. Having said all of that, in fact, if you look at um, numbers in COVID-19, it's clearly a lot of people had underlying anxiety or developed anxiety, but all these issues from stress to burnout to divorce to a whole spectrum to all the way to a traditional diagnosis of mental illness have increased significantly. Uh, Yet the issue that Faye just mentioned of how people try to avoid the issue completely, there was a study, a survey done at the Cleveland Clinic now during the COVID-19 by the group responsible for men's health. So they surveyed men now going through the COVID-19 crisis, and they found that about 3 out of 5 men experienced a significantly greater level of anxiety and related disorders than people had back during the 2008 recession. Yet, despite the fact 3 of 5 had significant level of this anxiety and mental illness, I think only a small minority of it would talk about it. The majority of which would, in the survey, said they completely avoid any discussion related to that mental illness. So this is another layer of complexity. To go to Cleveland Clinic, the response has been again early, in which we established, I think it is at Lutheran Hospital, which is where our main psychiatry group reside on West 25th, that they established a hotline 24-hour 7 for mental illness. I cannot, like Susan does, I cannot quote you the number of calls received and number of responses, but they were tremendous. I know, just to give an example, we during this COVID-19, we needed one of our psychiatrists to participate in an administrative role that we needed during this time. And he declined, the department chair declined, said we really are unable to cope with the number of calls and requests for help. So I think Cleveland Clinic intervention has been, the hotline has been education in language, in multiple languages to patients, and have been to ease access independent of the insurance coverage and so on.
Great.
I hope that made a difference.
Thank you so much. Well, appreciate all of those different ways that Cleveland Clinic has been working in this space. And I'm going to actually turn us over to a little bit of a different topic now. Recently, Cleveland City Council and Cuyahoga County Council passed resolutions declaring racism a public health crisis. Michelle, I'd love to start with you. What action steps do you expect to come from this work, and what action steps would you like to see come out of this work?
Apologies, my mute button. Good morning, all. I first like to start off by saying thank you so much for this question. It's so timely, or as I say, past time, to have this discussion and also actually get some actions in place around this. And I will also like to say thank you and much appreciation to Dr. Zein for initially including that in his first opening statement, how the racism as a public health crisis, in reality, if you break down what a pandemic is, racism is actually a pandemic as it affects us across the nation. So not just across the nation and then globally as well, with African Americans being at a disadvantage. So I just want to, again, thank you for the question and Dr. Zein for initially bringing that to the forefront of our minds to kick off this conversation. So my role, in addition to being a community engagement coordinator, neighborhood family practice, I also have the privilege of serving on the City of Cleveland Office of Minority Health Advisory Board. And I wish we could kind of bottle what we talk about and play like a snippet for you guys here, because you can see the connectors and the relevance within our conversation. And over the past, I want to say it's been 1.5 years, 2 years since I've been on that advisory board. At the foundation of everything, all the issues that minorities face across the board, racism and the policies associated with racism, or the policies that has been implemented that's been influenced by racist mindsets and biased outlooks, has impacted us across the board. So for my own personal feedback with that, as well as what I would like to see within our own organization, and I'll get to that in a bit to give you some insight of what we're doing at Neighborhood Family Practice. But from my individual position and then my position with serving on the advisory board as well as NFP, I think what a lot of us want to see, who's been disproportionately impacted with this throughout our entire life, is actual actions put into place, accountability for folks who say that this is going to happen, these policies are going to change. A declaration is a declaration, but a declaration without action is just words, right? So we definitely want and need to see action behind this declaration. Bringing this back to how it's affecting and heightening the situation right now during COVID, as Dr. Zein alluded to earlier, it already existed along with the socioeconomic status. But again, that is due in part, largely in part, due to these policies and systems that were put into place. And as the African-American young lady who grew up in the east side of Cleveland, both the southeast side and the northeast side, throughout my entire youth, we moved around a lot. I had a single mom of 3, so we moved around a lot. And I was able to live in different communities on the Cleveland's east side. And although many of us look like myself, probably about 98% of us in our communities look like me, we all had different experiences, but similar experiences. So our individual households was a subculture within the larger culture. But us as individuals living on the east side, experiencing what we experienced over there, it was normal. You didn't think that anything was unnormal about it until you step outside of your 2-mile or 4-mile block radius, and you start to see like, oh, it is more than what we have access to. I don't have a grocery store in walking distance. We did have one, and then Tops, they left out of there. And then we had to, when I was in St. Clair area, we had to travel further up the road when they put in the Save-A-Lot. So the lack of access is there in those communities. And when pandemics happen, such as COVID, that lack of access is heightened to unbelievable levels. And so, for instance, you have places like the Cleveland Food Bank where they used to just do the pop-up places where they would distribute food, or they will have their once a month food distribution where they serve, 400 to 600 folks. Now that number is up, like in the thousands, if I'm not mistaken. And they have to do it more frequently. And now I see pop-ups all over the city of Cleveland. So it's definitely heightened these systems that have been put into place, largely in part by racism and influenced by biased mindsets, has impacted folks first with the African American population. You have to think about it. Historically, these were created specifically for the African American populations to be at a disadvantage. And unfortunately, is what we call in the public health field the unintended consequences. Our international folks come over and they get relocated here, and other minority groups who are now living here in the US, they then become disproportionately affected by these systems that were put into place to negatively impact one minority group. So having that type of light bulb come on, and folks who are policymakers and who influence policy and who advocate on behalf of policy, when you think about it, policy, racism go hand in hand, and this is the foundation or the root cause of what we like to say in public health, the root cause of why our health outcomes are drastically poorer than our Caucasian counterparts, and why our babies die at a higher rate, and why we lack in every aspect of our lives across the board, across the spectrum. So with the Cleveland Office of Minority Health, the advisory board that I serve on, we sit at the table with not just African Americans, it's folks from Asia Inc., it's folk from our Native populations. One individual, he represents from the veteran hospital. I blanked on that. My husband is a veteran, but for whatever reason, I completely forgot the official name, but it's the hospital that serve our veterans and all of their healthcare needs. So across the board, we sit at the table in this minority representation. And what we find is that although there are unique differences, and some of us might have it a little bit better than others, there is a continuum of lack and being disproportionately affected, and our health outcomes are worsened by these policies. And these, unfortunately, policies that were put into place to keep a certain group at a disadvantage. And now across the board, this pandemic has heightened it. And unfortunately, more folks have been impacted that we would like, and they're dying at higher rates. And just briefly with neighborhood family practice, internally, we have started our diversity, equity, and inclusion committee, which I have the honor of serving on that as well. And that's first focusing on shifting our systems. So I think about that with the county and the city. The system shift, first do the in-reach and then do the outreach. So focus first in-house, and then that in turn will impact everyone else that we touch. So thank you.
Thanks so much, Michelle. Thanks so much for everything that you shared from your perspective. So many different perspectives, personal, organizational, and the work that's happening in the city. You mentioned policy, so I do want to give John a chance to jump in here and share from your perspective any thoughts you have on how we can move to action.
Thanks, Kirstin, and thanks for having me here today. I'm really glad to follow Michelle because I think she really sort of laid it out pretty clearly for all of us here. So I appreciate that, Michelle. I think first we have to recognize the painful history of slavery and racism in this country that has caused the disparities that we see for Black Americans, Black Ohioans in health and policy and structure of the safety net, how programs are created and set up. It's just replete throughout our history. And so we have the system we designed. When we wonder how we got it, we designed it this way. So there's three, and I want to appreciate what the city has done on this and sort of declaring racism as a public health crisis. The county, we're pushing for the state to do the same thing. There's legislation now pending happening, in the legislature that we've testified on. But I have sort of three ideas that I think folks might want to think about, at either a local level or at an organizational level. One is some communities are now requiring a racial equity impact assessment for policy decisions and legislation. Actually ask the questions, who's impacted by this? Who's impacted differently? Who's advantaged by a decision, and applying that to a policymaking lens. So I think that's one idea. The second piece is something that I talk about a lot, and that is beginning to disaggregate our data by race. And I'd say gender as well, because too often we just look at the data like how many people served, but we don't sort of dig into it and understand who's getting served, who's having positive outcomes or negative outcomes, which populations are doing better. And so I think that, and it's not easy to do, it takes changing systems and things like that. But even if you just sort of picked one program or one service that you offered, either at a clinic or a hospital or at a municipal level or wherever, and said, this one we're going to disaggregate by race and sort of see what the differences are, because we'll learn something from that. If you don't know what's happening, you can't fix it. You can't sort of target your interventions to have more effect. And then the other thing, I was really pleased to see the announcement of the Cleveland Foundation, this new fund that they're creating to sort of fund what I sort of think of as sort of racial equity work and anti-racism work. But I also think we could establish public funds to do the same thing, to develop programming for addressing racial disparities, for combating racism, and I think particularly for groups that are led by persons of color that primarily serve persons of color, because these groups historically are disadvantaged when it comes to funding. And so I think just being very explicit and intentional about trying to direct funding in that way could be helpful, because I think we would learn from that. So those are sort of the three things that I've sort of been thinking about from a policy standpoint or from an action standpoint, because I appreciate Michelle's words. A policy is just a policy until you figure out how to turn it into action. And I think that's the challenge in front of us.
Thank you so much, John. That was really wonderful how you laid out those three different things for all of us to be considering and thinking about. And I think those are wonderful things that we should be working on. Would love to hear now from Chief Walker Minor in terms of your thoughts on actions happening or that could be happening. Thank you.
Sure. And to come behind both of them to talk about this is so critically important. I remember back in March, Don Lemon was actually the first person that I heard say, and he said it on his evening show, that we are battling two pandemics. And he said it, I believe it was like March 20th, 21st, and I sat in my seat and thought, he is absolutely right. And racism has come to feel so good to so many of us, so normal, that I didn't even realize, because I'm so accustomed to it. It's a daily battle. It is literally a daily battle that happens, and we ready ourselves for that all day. Today, for example, I came out of my house and there were two police cars in front of my house. So they were in front of the house when I came down the steps. I made some oatmeal, and so that's like 6 or 7 minutes. I put it in a cup, I made the coffee, I hit the door to come outside, they're still there. So I'm like, what the heck is going on? And my heart starts racing. I have a Black 18-year-old son. I'm thinking, what's up? And that's my natural response. So I backed up, I speak to the cop, I said, hey, what's up? He was like, oh, there was a false alarm across the street, and we're just catching up. He said, you should feel safe that we're out here. And I thought, the dichotomy of that, the instant anxiety that went up in me because of that situation. And so that's to tell you just the ongoing response to a pandemic that I've lived with for my 54 years. I think that Michelle said something that was critical that my sister and I talk about on a regular basis, and it's the subcultures in our community, because I grew up on the southeast side of Cleveland, in Ward 1, which was working class. On my street and in my community, probably about 80% women, single women, making it happen for their kids. And this is what we saw. And so we were told, how to respond, what to do. And we were accustomed to seeing these women either catch the bus or work 2 jobs to make it happen, to make these sacrifices for us, because the grocery store, before food deserts was cachet, we knew that the grocery store was 6 miles away. And, and before Uber was cachet, there were jitneys that you could pay to take you home with your groceries. I mean, those are real experiences that I've lived through. And so for me, when we talked about racism as a public health crisis and naming that in Cleveland, I instantly, wanted to be a part of that, because we've got to change the dynamics. I mean, intentional or non-intentional, when the systems disproportionately impact communities, and we think that that's right without correcting it when we are aware of it, we are just as guilty as those who put the systems in place. So we have to think critically about how do we dismantle these systems in a way that engages our stakeholders so that they too can see the areas that they have to rework. That takes time. This is not overnight, because everybody's not on board. And so in addition to doing the work, we have to continue to build the stakeholders in the community to be advocates for this. I was reading a report that came out, and I can email this. It's the Justice Collaborative Institute. And in here, they say, here's a fact, and I just wanted to make sure I said it. Between March and July 2020, 5 months, March and July 2020, 84 cities and towns, as well as 42 counties, declared racism as a public health crisis. That tells you that this country is finally recognizing and coming to reckon with the first sin of this country. And it manifests itself majority in our health. It manifests in our health, and that's why it was the easiest way to document it in the form of data, to make sure that people could understand it. Because it was literally 35 years ago in the Reagan administration that the Office of Minority Health was first created, in the Reagan administration. People are surprised when I share that with them. It's a little known secret, but the Office of Minority Health was created with the Director of Health under Reagan and the leadership of Morehouse School of Medicine. And so those are the things. And so, when I learned that, I'm thinking, you've got to be kidding me. So it's taken all this time to get to the point to talk about the things that they talked about. In 2003, the same report, this same report talks about in 2003, so now it's 25 years after the Reagan administration, the Institute of Medicine issued the landmark report, Unequal Treatment Confronting Racial and Ethnic Disparities. This is not new. I share all that to say, this is not new. We've known this for a long time. Dr. King said it in 1967, when he said it, of all of the atrocities in health of people of different nationalities and ethnicities is the worst. It's the most egregious. And that happens because of food deserts. That happens because of poor schools. That happens because of lack of transportation. That happens because of lack of affordable housing. Those are the things that are comprised of the social determinants of health. And we have to view it from that lens, so that we can begin to affect change in those systems, in those institutions that continue to hold us hostage, so that we can make sure that there's equity for all. I mean, the founding fathers did get it right when they said, we the people, in order to form a more perfect union, equity, justice, fairness. We've got to get to that, because while they talked about it, they didn't do anything about it. And that's what we are pressing forward on when we talk about racism as a public health crisis.
Thank you so much. so bummed that we have to end the conversation in a couple of minutes, because actually it was the perfect segue into the discussion about social determinants of health. But I've really appreciated everybody's comments today, your time, the thought and preparation that you put into this. And I just want to also give my thanks to Beiju and the team at Global Cleveland. Thanks so much.
And I also want to thank Kirstin and all of our panelists today for a very thought-provoking conversation this morning that will be on the Global, it's been broadcast by Global Cleveland. As we've come to the end of this event, it's my duty to let you know that we also have additional events today for Global Cleveland. So there's a cooking demonstration at 12 for Nepalese food and a Latinx perspectives panel at 2 p.m. today. There are also events, as you know, going on throughout the week. We encourage all of our listeners and viewers to participate. Thank you everyone for joining us today, and have a good day.